The consumer analytics team provides quantitative market intelligence that guides strategic business decisions. We explain market trends, predict how consumers will react to innovations, and recommend strategies for thriving in a changing business environment. We welcome any direct comments at jennifer.kent@parksassociates.com. Retailers, service providers, and device manufacturers are expanding the market of technology solutions that help seniors live safely and well in their homes. Our new research, Senior Living Technology for Safety and Independence, analyzes the existing and anticipated independent living needs among people ages 65 and older, as well as their family caregivers. It explores seniors' use of technology, attitudes towards and use of PERS and telehealth solutions, and tests interest and likelihood to buy selected solutions and services, including those enabled by smart home technologies and products. Key questions addressed include the following. What is the market size and characteristics for family caregiving solutions? What are the drivers and barriers of solution adoption? Which channels do consumers most prefer acquiring solutions from? What features and functionalities do family caregivers look for in solutions? How does the independent seniors market differ from the family caregiver market? How are seniors approaching the telehealth and connected health device markets? Our analysts are constantly studying this market and provide regular updates on the consumer healthcare market, including service features, key service differentiators, device adoption, pricing and business models, updates on existing players, and the impact on the caregiver market. To subscribe or request more information, please contact us at sales@parksassociates.com.
We are so excited to welcome you to our Connected Health Summit 2022 series. Throughout this year, we will gather and share Parks Associates' latest research on connected health devices and solutions for consumers and bring the industry together to share their vision of our future of healthcare. After 2 years of virtual events, we're also announcing the return of our in-person events in 2022. We hope you can join us as we gather again for impactful sessions with insights from industry leaders and best-of-class research from Parks Associates analysts. Nothing beats the knowledge, conversations, and community that come from meeting in an in-person setting. We survey 10,000 broadband households each quarter to provide the most reliable and accurate view of the connected health market. This year, Connected Health Summit addresses opportunities for new solutions, including smart home platforms, telehealth services, voice assistants, and wearables to empower consumers, caregivers, and providers with new insight into patient health. Healthcare and technology providers have the opportunity to have an extraordinary impact on health and wellness through new applications and services in chronic care management, remote access to care, independent living, and wellness and fitness. We will discuss consumer behaviors and changing demands driven by the pandemic and new business models, IoT solutions, and deployments emerging to target these new healthcare needs. Thank you again for joining us at Connected Health Summit.
Hello, everyone, and welcome back to the Connected Health Summit. Today's event is focusing on the topic of seniors and caretakers living independently. If you haven't met me before, I'm Kristen Hannock, Research Director here at Parks Associates. I lead our coverage of the health tech market, including senior living and independence. If you're joining us for the first time this year, welcome. Today is the last session of our Connected Health Summit track. Though as a reminder, you do have access to the full series of virtual events from this year. We hope to see you back next year as well, with our next Connected Health Summit event kicking off in January. As a reminder, in addition to the Connected Health Summit, we have a full series of virtual events, including our Connection Summit at CES, Smart Energy, our Smart Spaces Summit, new this year, Connections, as well as the Future of Video. Before we get started, I'd like to give a special thank you to our sponsors for helping to make this event possible. Our platinum sponsors such as ADT Medical Alert, Alarm.com, Johnson Controls, and Rapid Response Monitoring, as well as our gold sponsors, Becklar and Independa. And also a special thank you to our supporters as well. In terms of the agenda for today's events, I'm going to be kicking things off with a 15-minute presentation looking at some of our research data here at Parks Associates. Afterwards, we're going to be going into our first interactive panel of the day, looking into the topic of integrating technology and services to empower seniors in MDU settings and at home. Afterwards, we'll be doing our fireside chat with Andy Droney, Senior Director of ADT Health and Innovation Programs, followed by another panel discussion looking at the topic of hospital at home. So yes, let's get started in terms of our Analyst Insight presentation. So I'm going to be sharing some of the research we've done earlier this year, really taking a look at what has changed in terms of the senior living market and independence in general. We have seen that in terms of some of the major trends in 2022, we've really noticed that the pandemic has moved out of its crisis mode, which has had very much a widespread impact on the market. In terms especially of technology adoption, both at home by seniors and in terms of family caregivers and in MD settings as well. This has, of course, resulted in shifting needs and demands among all types of populations, as well as larger changes impacting the MDU space. One of the biggest impacts we have noticed has been the movement of larger MDU trends, such as smart apartments, into senior living, CCRCs, and other communities. Looking specifically at the impact of the pandemic, I mentioned that it has been moving out of crisis mode. Of course, over the past few years, we have seen the more widespread availability of vaccines and treatments, which has led to higher resiliency of general populations. There is still, of course, a higher degree of risk to vulnerable populations, but lower than it was during the height of the pandemic. We can, by and large, expect this to be the new normal going forward. We have seen in our consumer survey data that as a result of this, there has been a lower demand for some of the caretaker solutions that were very much needed during the height of the pandemic in 2021 and 2020. However, there has been an acceleration in terms of those with higher acuity needs needing more solutions. We've also noticed, as I mentioned, that the market has largely been changed forever by people's experiences. One of the biggest changes that we've seen has been this acceleration in terms of use of technology, especially technology used by seniors and by family caretakers. Looking at this chart, you can see some of the technology within the different age groups. A majority of seniors now own technologies such as smartphones. We have seen heavy smart speaker adoption. More and more individuals are owning also smart home devices and smartwatches as well. This increased adoption of technology is only going to grow over time as more and more seniors, younger seniors, begin to age upwards. So this is having a large impact in terms of the types of solutions that people are looking for, especially the independent seniors market. Looking at the top caregiving solutions today, we do find that PERS and medical alert systems, the traditional solutions, do maintain their lead. These are the solutions that most individuals think of when they think of senior living, independent living, and these offer the use case that many consumers and seniors and the family caretakers find most valuable: fall detection. But we are seeing among lower acuity populations and among the independent senior segments a growing reliance on the use of smart speakers and displays as an independent living solution. These devices also offer communications, entertainment, as well as that more traditional fall detection and even smart home automation and controls. We're seeing growing adoption and interest also of home sensor systems, which offer some more advanced capabilities over PERS and medical alerts, as well as growing interest in smartwatches and DIY solutions using smart home devices. I mentioned the independent senior segment. So younger seniors as a whole are very much different than older seniors in the 80+ population. In terms of the solutions that seniors use themselves for independence and for maintaining their own quality of life, we do see high adoption of smart speakers, with many consumers using these technologies. We're also seeing, as I mentioned, growing adoption of smart home devices and smart watches. These devices as a whole have high adoption among general consumers. There's a lot of interest and a lot of use cases, but they also offer an easy transition between general consumer use as well as independent living. Many of these are, in fact, the same hardware that consumers would find just in a general retailer store. We do see among independent seniors, however, a lower adoption of some of the devices and solutions that are aimed specifically at independent living, PERS and home sensor systems. And that's because as a cohort, the independent seniors are generally less in need of these high acuity types of solutions. One of the other trends that we have noticed is seniors are continuing to make heavy use of telehealth services. Use of telehealth among the senior population and among consumers overall hit its height during 2021. Since that time, we have seen roughly a 10 percentage point drop compared to last year. However, a majority of consumers do still continue to use telehealth services, and adoption remains high among senior population. In 2022, around 36% of our survey respondents aged 65 and older reported using telehealth in the past year, which remains a vast increase over the pre-pandemic levels, only 6% in 2019. So certainly coming out of the pandemic, something that many companies, many solutions providers are going to have to keep in mind. The market as a whole has really changed quite a bit compared to where it was in the past year. We've seen overall somewhat of a lower demand for different types of solutions. We have seen more interest in higher degrees of technology. We have seen an increasing bifurcation of the market where the lower acuity needs are different than the higher acuity needs. We're also seeing that consumer awareness as a whole is dropping. The market has become increasingly complex and fragmented. Family caregivers and seniors need help to navigate this increasingly complex market. So education is going to be increasingly important going forward. I also mentioned a little bit about some of the MDU trends we're seeing. In the larger MDU space, smart apartments, senior living, we are seeing that many communities are increasingly making use of technology in order to ease staffing shortages and improve their internal operations. We're also seeing many communities increasingly use technology as a differentiator in order to stand out for their peers and attract more residents that they would find desirable. As with consumers overall, and as with other markets, there is a growing understanding among stakeholders of the possibilities of new technology, the use cases they enable, and in the healthcare specific markets, the ability of some of these solutions to improve both the quality of life as well as care outcomes. However, the senior space has some unique challenges that can introduce some difficulties. Many communities might lack, for example, the types of technical expertise in order to manage some of these solutions in-house. In many communities, there's also oftentimes a lack of key networking infrastructure, such as Wi-Fi, and many areas of facilities and communities, such as memory care units or possibly seniors' rooms. Many communities also face significant cost constraints, though of course there are many different players at all stages of the market. To discuss some of these trends and more, we have a very interesting panel that's about to take place, looking at the role of integrating technology and services as well to empower seniors. So I'm very happy to introduce our great lineup of panelists today, including Adam Green, CEO and founder of Clatch, Shannon Guzman, a Director of Housing and Livable Communities and Enterprise Housing at AARP, David Lafferty, Chief Information Officer at the Riverwoods Group, Brandon Neustadter, VP of Sales at CommuVision, and Michael Scaff, CIO of the Jewish Senior Living Group. Okay. Adam, can you tell us a little bit about yourself and about Clatch?
Sure. So my name is Adam Green. I am the CEO of Clatch, and I lead a diverse team of data scientists, social connectivity experts, and other professionals, all committed to solving the epidemic of loneliness among older adults. I found that to understand what Clatch does, it helps to tell the story of Sarah, a senior living executive who runs a CCRC community. Every day, she tries to ensure her residents are happy and healthy while increasing occupancy, length of stay, and overcoming staffing issues. She knew that loneliness was a big problem impacting her residents and KPIs, but didn't know what more to do until one day a colleague suggested she sign up for a social quotient subscription. Clatch made implementation easy. They trained her team to have short residents, and using their natural language processing technology, they produced a social quotient score for each person. Clatch used the score to generate a personalized recommendation for each resident, and we found gaps in programming and onboarding and recommended improvement. We used our algorithms to recommend changes to common area design to measurably create more social connectivity, and we provided dashboards to track progress and report results. Until one day, Sarah saw higher social quotient scores and happier residents. Because of that, employee turnover decreased. Occupancy rose as the sales team promoted social quotient metrics, and healthier residents increased length of stay, driving higher NOI. Until finally, Sarah came to work and saw the kind of community she wanted to live in.
Thank you so much, Adam. It's certainly looking forward to hearing your take on some of the challenges we're seeing right now in terms of social isolation and seniors, as well as more about the very interesting solution you have to offer.
Thanks.
Next, Shannon Guzman, can you tell us a little bit about yourself and about what you do at AARP?
Sure. Thanks, Kristen. Hi, good afternoon, everyone. My name is Shannon Guzman. I'm Director of Housing and Livable Communities at AARP's Public Policy Institute. We do research and analysis on policies that impact the 50 plus and their families and make recommendations and encourage solutions that improve the quality of life for them. So more specifically, I work on housing and livable communities issues and create resources to help individuals make informed decisions about how and where they want to live, and help communities take action to create places that make them more livable for people of all ages. The information on my slide, which you'll have, I think, shared with you, shows data related to the lack of access that some older adults encounter to broadband or high-speed internet, but there are solutions that can help. So I'm glad to be here with you today to discuss those.
Very happy to have you here today as well, Shannon. I'm very much looking forward to your take on some of the important topics that we're going to be discussing.
Great.
Next, David Lafferty, CIO with Riverwoods Group.
Hi, thank you, Kristen. Good morning, everyone. Dave Lafferty. I'm the CIO for the Riverwoods Group here in New Hampshire. We are the largest independent not-for-profit family of continuous care retirement communities in New Hampshire. We manage 3 campuses in Exeter, Manchester, and in Durham, caring for about 1,000 residents each and every day. Very happy to be here and join the panel. Thank you.
I'm Very happy to have you here as well. Okay. Next, Brandon Neustadter, VP of Sales at CommuVision, and I'm apologize for pronouncing your name wrong, Brandon. I know I did.
Oh, it's okay. That was pretty good. Well, thanks, Kristen and Parks Associates for having me. So yeah, my name is Brandon Neustadter. I'm the Vice President of Sales for CamuVision and CamuCare Fall Management Solution. About the last 10 years, I've worked in AI, IoT, and smart building industry. So CamuCare is a vision AI-based fall management solution that runs 24/7 to ensure that people are safe. So when it detects a fall, we actually send a short blurred video to our fall experts that verify whether or not it was a fall, so that anytime a notification goes out, the caregivers know that it was indeed a fall. So once that fall is verified, those caregivers actually get notified in under a minute, and that can be a phone call, text message, email, or a push notification through a mobile app. And then really importantly is they get immediate access to an unblurred video so they can see what led to the fall and really what happened during the fall so that they can provide the person the appropriate care that they need. And we're also really excited to be announcing that in the next 60 days, we're going to be releasing this technology to consumers so that everyone can benefit from a Vision AI-based fall management solution. So thanks again, Kristen, Parks Associate, for having me.
No, we're very happy to have you. Certainly looking forward to hearing what you have to say, talking about some of the new technology that's being used in MDUs.
Great, thank you.
Next, Michael Scaff, CIO of the Jewish Senior Living Group. Oh, Michael, I think you might be muted. We can't hear you.
There we go. That's the right button. There we go. Michael Scaff, CIO of the San Francisco of the Jewish Senior Living Group. Excuse me. It's been a busy morning already here, and we serve seniors and older adults across the San Francisco Bay Area and beyond. We are the largest private nonprofit skilled nursing facility in the state of California. We run an acute geropsych hospital, and we also run a beautiful new assisted living memory care community here in San Francisco. Very excited to be here and look forward to the conversation, Kristen. Thank you.
Thank you so much for coming. It's I think we're going to have a very, very wonderful conversation today with a great mix of perspectives across the vendor space, CCRC, SNF, as well as looking at policy. So yes, let's kick things off by talking a little bit about how the market has changed and how things have generally changed. So you all have really a wealth of different perspectives coming at this in different ways. So David, maybe to kick us off, how has the market and overall needs really changed coming out of the active phase of the COVID-19 pandemic?
Sure. So it's interesting. I think one of the things that COVID really solidified is the fact that healthcare staffing challenges are certainly here to stay. I mean, clearly we had a number of challenges in our industry even prior to COVID, but I think now as individuals, try to reassess, what they want to do and where they want to spend their time, coupled with a challenging economy that we're dealing with today, it's really solidified that as a reality now that we're all having to face. But I think the plus side, what's benefited us is that our teams have learned a new level of adaptability. Throughout the pandemic, we had some interesting examples. We effectively shut down our landscaping teams for a great period of time. Those individuals quickly pivoted their roles into setting up health screening and checkpoint locations throughout our campuses. Our dining teams, for example, all of our dining rooms were closed, which was obviously a significant challenge, in a community that's designed around socialization. So we had to quickly pivot and come up with new ways of serving, providing meals in the home, modified menus, and so on. And I think lastly, what we're seeing is that things like contact tracing, that's now effectively, I call it muscle memory for a team. It is, sadly, something we do on a regular basis to keep our staff and our residents safe. But it's just the reality of what we need to do moving forward, and we're able to do that much more effectively. I think lastly, as you touched on earlier, we've definitely seen a dramatic increase in the adoption of technology in senior adults, in particular around things like socialization and telehealth. So that's kind of my take on what we've seen over the past couple of years.
Yeah, certainly some big changes in terms of internal operations and in terms of the solutions you're using as well.
Yep.
Adam, can you speak a little bit to some of the changes you're seeing in the market? You have a bit of a different perspective as a vendor serving these types of communities.
So I think what we're starting to see is that, as we've seen in other industries, the adoption of analytics and better understanding how we can use analytics to improve quality of life as well as KPIs within a community are really starting to get recognized. I would liken it to something that happened in the human resources industry, where you had, for example, new technologies and employee engagement that came into the market and drove improved engagement to drive greater productivity. I think that you're going to start to see more and more of that kind of analytics and use of data. The other thing I think you're going to start to see is you're going to start to see the integration of social determinants of health with health data that really needs to live in places like David's community at Riverwoods, where that's the nexus of really understanding where people live and how they're living and what their behaviors are and what their health challenges are. And if we can integrate those two effectively, I think we can really drive improved quality of life and much better health outcomes. So what we would call healthy life expectancy can really grow.
Yes, which is certainly a big priority for everyone going into these types of communities, as well as the people who love them. Brandon, I know, can you speak a little bit to some of the trends you're seeing in this market in terms of maybe customer demand and where you think things are going?
Sure, absolutely. So, I mean, we work with companies both in senior living and outside. I think overall what we're seeing is that a lot of companies are looking more at their long-term strategies on how they can provide more and better services to their customers with less people to do it, right? So I think staffing shortage is not exclusive to the senior living or home care industry. I think a lot of companies are having that. And so one of the ways that they can do that is to use AI to understand and analyze environments, their customers, their employees, and be able to provide insights and notifications on what's going on in those environments, both accurately and quickly, and then so that's basically really extending the reach of that staff so that they can do more with less. So we're seeing that really across the board.
Yeah, so that's certainly a trend I've heard is ongoing in the MDU space as well. So certainly a lot of need with so many people gone from the workforce. Shannon, I know you have, from the AARP's point of view, you have a much different view of the market and everything going on. Can you speak a little bit maybe to how different companies, different providers are offering different ways of doing things? And maybe is there an evolved need overall for community and socialization?
Right. So what I wanted to speak to was really about how the pandemic illustrated the need to make communities much more livable. That means, having the services and amenities and features available to individuals in their homes and the larger communities to help support people as they age. We actually developed an online tool called the Livability Index, which was recently updated this year, that assesses communities for services like healthcare, high-speed internet, healthy food options close by, places to exercise and socialize, like parks. And so during the pandemic, those features and services, especially broadband, were critical for many older adults for being able to stay in contact with friends and family, seeing their doctors through telehealth visits, and being able to access local information, both about the pandemic and what was going on in their community. So I do believe that businesses and services that were able to be adaptable, as what was mentioned before, to meet people where they were, to support them in whatever their particular need was, in getting food, being able to get outdoors, being able to connect with folks. I'm particularly thinking about places of worship that were able to have online services to help people not be socially isolated and still be able to connect with the community. Those things were very important.
So certainly that's very, very much critical in the times of distress.
Mm-hmm.
So yes, Michael, one of the things that we spoke about not too long ago and that I mentioned in my presentation earlier was this really increased use of telehealth adoption and also remote patient monitoring among seniors. As a SNF provider, a skilled nursing facility, as well as a CCRC, you must be seeing a lot of these trends as well. Can I ask, what are you seeing in this space right now in terms of telehealth and RPM, and what do you expect to see in the coming future?
We've certainly seen growth over COVID when people couldn't get face-to-face, when providers or doctors couldn't get face-to-face with their patients. That certainly led to a growth in telehealth. We were one of the first skilled nursing facilities in the San Francisco Bay Area to have a red zone, which was COVID only. So we had to get creative in a hurry with how we were going to adopt telehealth and make sure that we could maximize access to the patients that needed the doctor's attention, but keep them safe at the same time as well. So I think we've seen it in the community space, but we've also certainly seen it out in the broader community. Although one thing that AARP has done a wonderful job of, and I want to just give them kudos here, is identifying and focusing on the digital divide, which is still very much a real issue for many seniors around both the US and the world. From a connectivity standpoint, from an education standpoint, from an economic standpoint in some cases as well. So there's this aspirational view of technology and what it's capable of, whether it's RPM and telehealth, some of the fall prevention or other technologies that work both in our senior communities and in people's homes. But there's also a gap that has not been filled yet, that is the digital divide, that we all need to focus on as well and understand how we could best bridge that so that these technologies can really achieve their maximum efficacy and we can do the good we want to there.
Yes, I think for many folks there is a misunderstanding thinking that the U.S. has full connectivity for all households, but the digital divide remains a major challenge for many people in many communities, especially for seniors.
Yes.
And Shannon, can you mention, so you talked a little bit about some of the changes you're seeing in the market. Really, what are you seeing in terms of technologies and services that are having maybe the greatest impact with quality of life and health improvements among different communities?
Right. So, we know that high-speed internet is very critical because so much of what we do in our lives, we do online, from socializing to doing our work, as evidenced here today, education and entertainment, among others. And it's really important for older adults to be able to stay in touch with their healthcare professionals. They may be dealing with lack of transportation and not be able to see them in person. They may be dealing with mobility issues or challenges or live too far away. So being able to access and understand the technology in order to, have healthcare visits is very important. As you mentioned, Kristen, earlier, there is more interest in smart technology in the home, and those can be definitely beneficial for older adults who want to stay active and independent. So we have the video doorbells and cameras and home systems to control HVAC systems and lighting to create a much safer home environment for someone who's aging in place, but they also can help a caregiver for monitoring those things for a family member who is still independent but may need help sometimes. But as Michael was saying earlier, there is still the issue of people not being able to access high-speed internet for a variety of reasons. And so, we need to look to certain solutions to bridge that gap.
Yes, and one of the big benefits of the last few years has been the acceleration of different programs aiming to bridge the digital divide, increase connectivity, increase download speeds across the United States. So certainly some improvements there, and certainly some more things to be done. Brandon, so I know you offer Commie Vision solution, fall detection. You have certainly some opinions on new technologies that can be rolled into MDUs and really help folks. Can you expand on your point of view a little bit?
Yeah, sure. So, I mean, we really do see a big demand for technology that can proactively identify and respond to problems. So, I mean, outside of fall detection, I think there's a lot of new products that wirelessly monitor vitals. That's really interesting because you can put those in people's rooms, whether in a community or in people's homes, and that can give a lot of proactive notifications when somebody is starting to maybe have a higher health risk for an issue. Of course, we're focused on using AI to help people better understand falls, detect them, and respond quickly. I think one interesting statistic that's always stood out to me is that according to the CDC, half of older adults don't detect or don't discuss falls with family or caregivers, and over 95% of falls go unwitnessed. And once somebody's fallen once, it doubles your chance of falling again. So by being able to detect the first fall or an unintentional self-lowering, say somebody's trying to put on their shoes and they end up on the ground, that's really indicative of a need that older adult has to maybe get some physical therapy or some strengthening, so they don't end up having that fall that lands them in the ER or the hospital. And so hopefully, we can start implementing strategies to prevent future falls and keep loved ones safe by being able to have earlier intervention.
Yes, and integrating more and more preventative care can certainly help lower cost of care quite a bit, as well as improve some of those health outcomes and overall quality of life for people.
Kristen, can I just jump in? One of the things I want to add to what Brennan said is, and also what Shannon said, is all these things are interconnected. And ultimately, there's got to be a lot of collaboration between, I would say, technology providers as well as the communities. The issues related to fall detection are often related to issues like loneliness. And once people become lonely, very often they're not getting enough exercise, or they're not eating properly, or taking their medications correctly. And so all of these issues start to overlap. And I think what's important going forward is people really need to be open to collaboration and to come to the table with that view, because I think there is amazing technology out there right now. It's developing all the time. Seniors are showing that they're willing to adapt to that technology if it's introduced in the right way. They're interested in it. They everybody wants to be the cool person on the block, right? It's fun to have new technology at any age. And I think if we start to work together more and integrate our activities more, the likelihood that we can build what I would call a new infrastructure of community really goes up.
Mm-hmm. Yes, and integration has always historically been one of the biggest challenges with technology, especially in the medical space. So certainly a lot that needs to be done, but very much enormous potential there as well. David, can I ask, so as a CCRC provider, what types of technologies are companies like yours actually investing in terms of maybe the whole approach? Is technology seen as kind of a cost saver or a cost center? Is there maybe an impact on staffing shortages that you're seeing? And what is kind of the overall impact on communities?
Yeah, well, it's interesting. It's actually both. So, we are heavily invested. We're all in on the technology front. Certainly, we don't invest in technology just for the sake of doing it. We want to be certain that we're looking at the right use cases and that we have a measurable benefit or outcome, whether that is in resident service, care, safety, or in cost efficiencies. So interestingly, we look at technology significantly to augment or offset the continued staffing challenges we talked about. Some of the things that we're investing in, robotics, it's a very popular field right now. There's a lot of amazing technology out there, although the use cases are still somewhat limited. We are using today dining robots in some of our facilities. They are somewhat limited, and it's not entirely clear to us yet that it is going to be a definable rather offset in staffing, but it's certainly something that helps us in that regard, even when it comes to things like busing tables and so on. But also some of the more common use cases that we're looking at, particularly in regards to cleaning of common areas, as well as common area disinfecting using ultraviolet technologies. In addition to robotics, one area that we are very excited about is non-intrusive technologies to manage our residents in place in their homes. We're looking at some solutions right now based on ultra wideband radar technology, or UWB, that are fascinating because they enable the ability for non-intrusive monitoring of things like respiration, heart rate, fall detection, ambulation, even in some cases, toileting. This technology is interesting in certain care settings such as skilled care or hospice. It can even be an indicator of pain management effectiveness just based on respiration and heart rates. So we look at that a couple of different ways. One, we think that technology can help optimize our staffing models. So as opposed to a conventional rounding sort of staffing model, particularly in the overnight hours, this technology can better indicate to our care teams, which residents require care and monitoring, and make it a bit of a more targeted approach. But we also look at this in terms of market differentiation, right? The ability to provide a service where we can offer a higher level and a higher quality of care for our residents. So, overall, these investments certainly help us control or limit the impacts to things like our monthly service fees for residents, because we're just more responsibly managing our operational spend. We can avoid more staff. We can perhaps offset wage increases for staff that are necessary because of retention reasons. But again, we want to be certain that we've got a clear and definable use case. So we're being very careful and deliberate in our approach, but certainly we're excited to leverage this technology. I think it holds a lot of promise for additional benefits for us.
Yes, I think being careful and deliberate and making sure what you do actually has a good ROI and you can maintain it going forward is absolutely essential for long-term success. So Michael, I'm very interested to hear your thoughts here as well. You're in kind of a similar boat, looking at different technologies to invest in the communities.
And I share David's optimism and focus on these different types of technologies, especially around staffing. For example, some of it is really sort of an extension of what I would consider traditional IT technologies or IT-centric technologies like staff management or nurse shift management, which for an organization that has hundreds or even thousands of nurses, it's a little like air traffic control. So these fairly simple, straightforward technologies, or at least what looks like simple at the surface, really can make a significant difference from an operational standpoint. I served for a few years, not just as our CIO, but as our COO as well. So I was responsible for our operations and got a firsthand look at how complex managing hundreds and hundreds of nurses every day with call-offs and everything else, and challenges that really exacerbate the labor challenge that everyone is facing. David is, we are, everyone across the US is facing this right now. So it's a blend of technologies from what I consider more traditional sort of enterprise technologies on nurse shift management or applicant tracking to increase the velocity of our ability to go out and source and find good candidates, to some of the more healthcare centric technologies. I'm also very optimistic, as you mentioned earlier, around some of the technologies behind voice platforms, because finally we have a user experience and user interface that is a little more friendly, a little more engaging, and a little simpler to pick up and use, that can be the front end to a lot of these really exciting sensor-based technologies without having to deal with the fragmented user experiences that up until recently have been the norm. I built one of the early senior smart home pilots about 7 years ago. And frankly, it was a fragmented challenge and conglomeration of technologies that didn't interoperate terribly well. And to your point, Kristen, that the data was challenging to integrate. We are finally evolving past that. We are seeing platforms that understand interoperability of data. The EHRs are finally understanding the capability of this as well. We're seeing CRM technologies finally show up blended with EHR as well. So it's not just a billing system, but it actually tracks what people want and what people care about. So I'm very optimistic about both what is possible now with technology and the real benefits that are quantifiable now as well with technology.
Yes, I think a lot of, as you're saying, Michael, some very exciting forward momentum. The Matter standard also just got launched, I believe, yesterday, finally.
Yep, finally.
So hopefully integrating all these devices is going to be easier in the future as well. So yes, Adam, I guess kind of a similar question to you. What do you see these different communities investing in, and actually how are they approaching some of these investments?
So what we're seeing is that I think in some ways similar to what people have said earlier, it's really about ease of use, right? And not just for the residents, but also for the staff. You've got a staff that I think someone mentioned earlier, it's traditionally been a challenge. There's been high turnover pre-pandemic, and the pandemic made this more challenging. I do think that people are starting to become aware that there's an opportunity to use wellness to drive improved results on the bottom line. That, healthier, happier residents are much less of a drain on staff resources, create much less stress on the staff. How to get there, I think, is still being figured out. But if I had to think about one thing, it's really ease of use and implementation. There's no use in giving somebody this fantastic tool that's too complicated for them to operate. And that occurs, from what we've seen, more often than not, even on things that shouldn't be complicated. Sometimes out there, they seem to find their way into technology that ultimately it's not worth it because they're spending so much time figuring out how to make use of it. And it's something that we've focused a lot on, that to make it easy to use everything and to give the people the information they need when they need it is really, I think, a key.
Yes, I think there's an enormous challenge in terms of having a UX for medical use cases, for some of these other use cases, that actually provides all the information you need and is customizable enough for different people's unique needs as well. So it's certainly much more complex than many other areas where tech is served. I guess, Brandon, what is your take on some of the investments you're seeing?
Yeah, so I mean, I think I agree with David saying, we see a lot of communities investing in technology to differentiate themselves, right, in the market and from their competitors, and to also, when families come and they're looking for a place for their loved one, to be able to show the extra services and the level of care they provide. When we talk to executive directors and directors of nursing and talk to them about CAMI care and fall management, I think everyone sees the value in that. And especially with the staffing shortages, I think they're all looking for ways that they can provide more care and better care with less. And also the staff really appreciates it, right? Because sometimes they can't do all the rounds they need. So if you have a resident who's more at risk, they maybe aren't able to check on them as often as they'd like to, right? So by implementing these kinds of technologies, it can make the staff more efficient. It can keep residents safer. And families feel better about moving their loved ones into those communities, right? I think I was talking to a CFO the other week, and he was saying that the average age of somebody moving into their communities from pre-COVID to post-COVID is up 5 years. So the people moving in are 5 years older. They have a greater level of care that they need. And, and then they have the challenge that they don't have as much staff for the amount of resources that they used to. So you have more people who need and sometimes less capability to provide that. And so looking at ways they can implement technology to extend their reach.
Yes, I know there's also been some worrying reports about the long-term effects of COVID infection. We don't quite understand the extent to which that's the case, hoping to understand more, but it looks to potentially be a big challenge for lots of folks. So yes, Shannon, something that I'm interested in hearing from your take, AARP's take. What are some of the key drivers and also barriers for technology adoption into these communities? And I know you can talk a little bit to the barriers perspective as well as some of the solutions you might be seeing.
Sure. So, again, pointing back to some of the data points that I had on my opening slide, what we're seeing is that just a lot of people are in that gap. They're not able to access high-speed internet or have access to newer or smarter technologies for various reasons. One is that there's no infrastructure, no broadband infrastructure where they actually live in their communities. It just may be too costly for a jurisdiction to install on their own. But some communities have tapped into federal or state funding and partnered with local businesses to establish broadband networks that can bring high-speed internet into homes and businesses. One example of that is Arkansas City, Arkansas, which recently received funding for broadband infrastructure. Some other communities also build free local networks, Wi-Fi networks, if their states allow them to do so. But this can also be an opportunity for community members to be able to access the internet free of charge if cost is a barrier for them. Another thing is if people aren't able to afford access in their homes, then there are other types of programs like the Affordable Connectivity Program from the federal government that offers financial support, monthly support for lower income households to have monthly internet access. And there's also some libraries as well. And this is why, having certain amenities and services within the community is so important, where people can get access to the internet and computers. Some libraries have lending hotspot programs or hotspot lending programs for their members to use the internet at home. And AARP was instrumental in providing funding in Oklahoma for the expansion of this type of hotspot lending program in libraries across the state. Also, people may be intimidated by using the internet, as others have mentioned here, or other smart devices. They may want to engage, but just not be sure how to. And so there are programs to promote digital literacy. Again, some libraries offer something called digital navigators, so technical assistance to train people on technologies, different technologies and how to use them. And then AARP has an affiliate called OATS. And through their Senior Planet program, they teach technology classes and offer technical assistance as well to help older adults get started on their tech journey. But it's also just a means to stay engaged, be independent and active. So technologies is the means, it's not the end. We want people to be able to use these tools to stay engaged and continue to feel a part of their community and continue to feel that they can age in place independently.
Yes, and thank you so very much, Shannon. I think we're seeing a lot of some very exciting trends there. You talked a little bit about seniors living kind of independently in the community, getting more and more access to internet through different means. We also saw over the past year the launch of 5G home internet service being provided over mobile networks. And T-Mobile has actually had some fairly enormous success. So they busted into the top 10 home internet service providers just based off of their mobile network. So certainly a lot more is available to consumers these days. So David, I think also very much looking forward to hear what is your take on some of the key drivers and barriers for technology adoption in communities.
Yeah, no, it's interesting. As Shannon mentioned, you certainly have to consider demographic barriers, right? Financial barriers, perhaps access to services in rural areas and so on. But it's fascinating because AARP published a study around senior usage of technology, and it's kind of an interesting confluence of factors. So, first off, tech spending among older adults increased almost 200% from 2019 to 2020. So certainly you can say that COVID had an impact on that. Ownership of smartphones increased 60% for adults age 70 and over. Yet 75% of those same seniors age 70 and over prefer to learn new technology hands-on from someone they trust. And I think we're learning here in our communities that is a key barrier. It's how the seniors want to learn. It's not that they don't want to, but it's how they learn how to use that new technology. So examples of what we see, as you mentioned earlier, Kristen, we routinely get support requests for things like smart picture frames, smart lights, speakers, smart TVs. Interestingly, I reviewed a report the other day. We had a resident requesting support for an electric smart blanket. So they wanted to integrate their electric blanket with their Alexa home device. And those are typical requests. Those are not necessarily all one-offs. So to address those barriers, we actually created a new role here. We call it a resident relations associate. This is an individual that doesn't live in IT. They live within our community life or our community support teams, but they have a particular customer service and technology focused skill set that their role is really designed as more of a concierge style service. So the type of support they provide, hands-on, one-on-one, classrooms, they work by appointment. It's quite honestly the opposite of what I call utility IT, keeping the lights on. So, our typical IT role, we keep the Wi-Fi up and running, we keep the telephones working, but that's kind of where it stops. And this role, we've seen great success in 2 of our 3 communities. We're actually planning on doing it in our 3rd. But that's how we're specifically addressing some of those barriers that we're seeing with our residents today.
Mm-hmm. We've had some folks from the Best Buy Geek Squad come and talk at different Connected Health Summit events. And that's actually one of the biggest use cases they're seeing as well. So being able to provide some of that hands-on training of different technologies for seniors. Michael, can you tell us maybe a little bit about kind of what you're seeing in terms of some of the big drivers and barriers to technology adoption?
Yeah, and similar to what David and Shannon were talking about, very familiar with the Oates folks. They do an amazing job. You'll see this now both in the communities, as David is doing with a dedicated person. There are companies out there like Get Set Up that are doing a great job of this as well. So part of the digital divide that is often forgotten about, unfortunately, is the educational aspect. It's people focus on connectivity, which is, of course, a fundamental barrier, but you also have to have both the economic capacity to afford a device and then the understanding of what to do with it. Not to mention how to keep it maintained and patched and everything else so it doesn't become more of a risk than a utility. But as digital tools become really the front door for a growing number of critical services, this is a really important thing to consider because it's not just healthcare, it's transportation. It's a number of other critical services that are now sitting behind digital front doors increasingly. So it matters more. This digital divide matters more. And part of what we do, what David and team does, I'm sure as well, is this is part of what senior living does, is provide these tools in an integrative fashion with a concierge style approach to sort of ease that bridge or that gap. But also considering the tens of millions of folks that are living at home with unpaid caregivers that are trying to navigate this for themselves. And that's where you'll also see an important focus over the next few years, I think, where technologies and the services that sort of wrap those up together and coordinate the care, coordinate the services, and bridge the gaps to getting towards those is increasingly important. Adam talked about social isolation and loneliness and some of the social determinants of health. Finally, healthcare is appreciating the clinical value of the social determinants, which is wonderful. And we saw the prominence of the focus on that through COVID because both people living in senior living communities were isolated and certainly people living at home were even more isolated because those are not congregate living environments. So I think we're hitting a crux point where we will move through the integration of these technologies and services once we figure out the best ways to really bridge these digital divides from an access, from a connectivity, from a knowledge standpoint, and really unlock some of the potential for transportation, for healthcare, for other aspects, for fall prevention. Brandon really pointed out one of the major issues that's out there for seniors, both in senior living and in people's homes. As long as those become well integrated, they're not hard to implement because, again, a family caregiver is going to have a hard time implementing that if it's not a really streamlined UX and UI to put that in somebody's home. But there's enormous potential if we can get through that. And you increasingly see a higher acuity level in senior living because families are exhausted. They've done the best they can for the last 2 or 3 years caring for their family members that may have mild cognitive impairment or more than that, or other needs that senior living communities provide the assistance for. So in senior living, we're seeing a growing level of acuity in the residents that are moving in. They're older, they're sicker, they need more help. But you're also seeing that out in the community. So there's a challenge and an opportunity both that are very exciting over the next few years.
Yeah, so certainly a lot of movement in different directions, a lot of challenges ahead. And Adam, I know you were shaking your head a lot.
Yeah, I just want to add one quick comment, which is I think that there are existing technology that older adults are familiar with and know how to use, and that if they're reframed right, they really become a gateway to using these other technologies. The main one being the telephone, which we forget is technology. And yet almost every older adult knows how to use a telephone. And it has actually much more, partly because of the laws, it's more available in more places. So in rural areas, maybe only 50% of people have high-speed internet, but they have a telephone. And I think that one of the things that we try and do and that we encourage people to do is you can do a lot with the telephone. And once you have people on the telephone, there's a lot you can learn without having to have the older adult do anything. If you hide a program on the online on the telephone, you can monitor how often they speak in a group activity, and there are programs out there that are doing that. You can analyze what they're saying and how they're saying to better understand not just their some of these social determinants of health, like loneliness and things that we work in, but also you can actually diagnose various kinds of illnesses now just through the voice. And so I think once you frame it as technology to older adults, then it makes them a little bit more open, what we found, to some of these add-on additional technologies that then allows them to say, hey, this is just one more step. You have a telephone, now we're going to add a smartphone. You don't need to know 50 things. Here's one really useful application. Learn that one, that'll be great. And that, I think, can make a big difference.
Yeah, so certainly building on what they currently use and know helps make it easier to learn know new things. I believe
Kristen, I just wanted to add, one more point, and it's one more thought of consideration, that older adults may be concerned about are issues of privacy and also issues of potential fraud or risk to fraud for some technologies. And so it's just another consideration that I think individuals and communities need to be aware of as they roll out or start helping people with newer technologies as well.
I would just say, starting with that, the data that people create should be the older adults and the communities that they're from. It's, if we create data, that data doesn't belong to us. It belongs to those people who are there. And I think that's got to be a principle we all agree to.
Yeah. Unfortunately, we are about at time. I think it was a wonderful conversation. Thank you all so very much for being with us today and bringing our audience in on some of your viewpoints on this topic.
Great. Thanks
a lot. Thanks for having us.
Bye-bye.
Bye.
So next up, we have our keynote with Andy Droney of ADT.
If you miss a live session, you can go back at any time to watch on demand. Go to Watch Replays and click on the session that you want to view. Have you created your own event agenda and swap card? Visit the Agenda and Watch Replay tabs to add sessions that interest you to your own event. You can go back to My Event to revisit any bookmarked sessions, sponsors, and items. We want to make sure that you're connecting with our industry-leading sponsors. You can interact with them by visiting the Booths in the Sponsor tab. You can also bookmark sponsors or add items to your event to view later. Sponsors have uploaded extra materials for attendees. Make sure to visit sponsors that interest you to chat with one of their team members or save documents for later. We have dedicated meeting slots set up for break times between sessions. Continue the discussion by requesting meetings from others in the SwapCard platform. Schedule a meeting with another attendee or a sponsor by visiting their page. The panelists and speakers will be addressing your questions live during the stream. During the stream, use the question tab to ask your questions early in the presentation. Go to the poll tab to answer polls that will be discussed during the live stream. If you need help navigating SwapCard, please reach out to our team by mentioning @Parks Associates in the chat box or by contacting one of our team members via our company page. Welcome back. That was a really great conversation. I really love listening and learning as we go through these virtual sessions. My name is Elizabeth Parks. I'm the President and Chief Marketing Officer of Parks Associates, and I'm so excited to welcome Andy Droney to our virtual stage today. He's the Senior Director of ADT Health and Innovation Programs, who's spent over a decade working with ADT to help really build up their solution within the health and the PERS market. So today we have a lot to talk about, and ADT really is uniquely positioned as a service provider with all the security services they're offering to be able to, attach new devices and create new experiences for consumers. So we're taking questions throughout the conversation. Feel free to add them into the Q&A chat. We're going to talk about how the landscape has changed, who the core customers are for the PERS market, what's driving the market forward, the impact of Matter, which I think everybody, if you're not aware of, this is an important topic in the standards area in terms of interoperability, and really what the future looks like for the health and home market, and particularly for seniors and caretakers. So, Andy, thank you so much for joining us today. Let's go ahead and start with a brief introduction of yourself, your role at ADT, and where ADT sits within the virtual care and health market for consumers at home.
Thanks for having me, Elizabeth. I'm really, really happy to be here. That was a great panel that you just had, and I was like, man, I could chime in on some of these topics, so maybe we'll touch on some of those. But that was excellent. Again, my name is Andy Droney with ADT Health. I've been with the company for nearly 15 years. Done a little bit of everything. I've worked in field operations and sales on the security side of the business. I was on our innovation team for quite a while, and for about the past 4 years, I've led our health team, and we offer a suite of PERS-related products, medical alert products, and we're also working very hard at developing new products and new services for the senior aging in place space, where we can help our customers be protected and connect with the ones that they love, and really with the goal of trying to keep them at home in the place where they want to be for as long as possible.
stay living in their home and make sure that they can do that safely, especially as you get older. So let's start off and just go back. What brought you into this space initially? Where did your interest come from with this health at home market?
So I was working on our innovations team, and we were doing some work with our medical alert business. And luckily enough, the team that I worked for was also part of the team that kind of oversaw the health business. And my predecessor moved on to a new opportunity, and I had an opportunity to spend some time with our health team. And I told my boss at the time, hey, I really like to be a part of this and run this business. The thing that really that I love about this business, of the different jobs that I've had at ADT, this has been, I think, one of the most fulfilling. I get a report daily on the incidents that we have where we help seniors out, typically seniors or people that have issues, and our monitoring agents are just top notch. And it's really nice on a day-to-day basis to see how we interact with folks, help keep them safe, frequently save their lives. And it's just really fulfilling for me to see that on a basis of day in and day out. And really our team is top notch. Our agents that handle the calls are specially trained, and they only take our health related calls. And they just do an amazing job speaking with people and empathizing with them and the situations they have, and then communicating with either emergency responders or their caregivers or a neighbor if it's something that's less serious, to say, hey, you need to help out your neighbor. Can you go over there and give them a hand? And sometimes we just get calls from folks who push the button because they're lonely and they want to talk to somebody, and those can be very heartwarming conversations. But where we're looking is to try and drive beyond the PERS, the kind of the standard PERS offering where you push a button to get help, and really start to drive what can we do with all the smart home devices with ADT. Our partnership with Google is the largest smart home provider in the country. What can we do with all those devices to reimagine them to allow us to achieve that goal of having seniors stay in the place that they want to stay for as long as possible, and also make the job of the caregiver, which I think you talked about a little bit on your previous panel. Somebody mentioned, I wrote it down, that families are exhausted. How can we alleviate some of that exhaustion by providing products and services that do some of that work of checking in constantly, making sure mom did what she was supposed to do or took what medication she was supposed to take? How can we take that and move that off of the family caregiver so that they can have more meaningful conversations, so they don't feel like they're constantly nagging a parent or nagging their loved one to say, hey, what are you doing? Have you done X, Y, and Z? They can just say, hey, how was your day? What's going on? And they can have better conversations and better interactions with them if we can kind of take that off to the side and do that for them.
Yeah, absolutely. I mean, the role of technology is just so huge and can have such an impact in the day-to-day lives of the caretakers and caregivers, as well as the individuals. So let's talk a little bit about how the landscape has changed, specifically with PERS. You've been doing this a long time. Have we moved away from just the I've fallen and can't get up kinds of messaging, and also maybe speak a little bit to the technology evolution? How has the PERS market changed maybe from a decade ago to today?
I think two of the big kind of, I'll call them innovations now, they're kind of standards. Well, one of the big ones is mobile PERS. As I was getting into the business, that was had just started had been implemented, and people were very excited that, hey, I can take this protection that I have and go out and about and be more active and not be tied to, say, my home where my pendant won't reach. I can go out, and if I can drive, I can go to the mall, and if something were to happen to me. That was a really a big move forward. And most of the folks in the PERS industry offer that now. I think when I came in about 40 years ago, there was a big push on wearables. And wearables are great. I think there's definitely a spot in the ecosystem for wearables. All the great things that you can do with a watch and the data that you can generate off of a watch around different health parameters is really important. However, as we were talking before, some of the technology challenges with seniors with a watch are a little bit challenging for a wearable. Getting all the devices, all the sensors you want into a watch that's got maybe two-way voice and a battery life that's not a giant watch that a grandmother can wear around. So those can be challenges. And then just interacting with that device can be difficult for somebody that has dexterity issues or has eyesight issues and things like that. So I think there's definitely a piece on the wearable side. But I also think where we're trying to head is what can we do in the home to give those seniors a way to interact that fits them. It may be a wearable, it may be a voice assistant, it may be some other way to interact, and providing some flexibility in terms of what are the things that you're trying to protect against, what are maybe some of the health concerns that you have around a particular individual. Those are individualized. Not everyone has the same issues and may need to track different ailments, if you will. But what are the different interfaces that a senior may want? Some may want voice, using a voice assistant. Some may want to use a wearable. Some may want to use a tablet. So the ability to have different interfaces that fit with different folks and their desires, I think will be really important. And I think that will really help, the adoption and making it easy and seamless, as like I said, you talked about in your previous panel.
Yeah, so you're talking like a little bit about the passive technology that can create the monitoring in the background where there maybe isn't a requirement for a wearable. And in addition, maybe to somebody not wanting to wear the wearable, maybe they forget,
Sure.
they're supposed to. So those form factors, I think, are going to be important for the wearables. But where you all are going further with that, and many also are those sensors that can get placed throughout the home and are really focused on the predictive nature, right? Trying to stop something before it happens or recognize when it's happened, how to be able to respond, most appropriately and really, ultimately, if you can reduce the ambulances getting sent out, clearly you're helping that individual who doesn't need it. And also there's the obvious cost, of course, of an ambulance having to go out to somebody's home. So, this is the ADT and the State Farm and the Google and all of these, huge investments that are getting made into where you all are taking the business is, I think, very telling on the integration points across the home. So maybe you can speak a little bit more to these combination of devices, the bundles that are coming through, and, share whatever you might be able to with some of the direction that ADT is taking, not just specific to health, but really what we've been talking about for almost 40 years here is this whole home experience and being able to have this simple and easy and very useful, valuable services through, connected products.
Absolutely. So when you think about all of the different sensors, where our head is in all this, you think about all the different sensors that are potentially deployed in a home, be it part of a security system that may be a traditional system that's been there with ADT for years, maybe part of a home automation type system that controls lights and door locks and other devices in the home. We're trying to reimagine what can you do with those devices that may have traditionally been used to keep somebody out or detect if somebody got in when they weren't supposed to. That's all incredibly important. But also, how can you reimagine those devices to do a couple of things? Number one, how can you reimagine those devices to work from a smart, just a classic smart home perspective? Can I use a motion detector to create some scene in the house, or turn a light on, turn a light off? Can I lock up everything and shut it down for the night? Those are all important, not just for seniors, but for all customers, just to make kind of life easier. But also, how can I take the data that those devices are collecting, if you will, and synthesize it and draw some inferences as to what may be going on? And it may be different for somebody who's younger versus someone who's a senior or has a specific health ailment. So we're trying to reimagine what can we do with all these devices and all that data to say, potentially predict an incident that may be happening. You think about things on kind of the simple side is activity levels, water consumption, is medicine being taken, sleep, how long or how well people are sleeping, how many times are they getting up during the night, and gather all that data together and start to provide potential insights as to maybe a combination of data that we received doesn't necessarily require an ambulance, but it may require somebody to check in on somebody and say, hey, are you feeling okay? We saw some, maybe it's not even, we saw some strange things in the data that we got, but it's, hey, what's happening? Are you feeling okay? And somebody may say, no, I'm not feeling great. And you could potentially intervene ahead of time. Hey, can we get the doctor on a telehealth visit to check you out? And before it gets to a point where someone has passed out or someone's suffering from, say, something like a UTI or something like that, that's creating dementia issues, et cetera, how can you intervene in that up front and either get a telehealth visit or get somebody to an urgent care, to their doctor, versus having to send them to an emergency room or send them to have an ambulance come out and pick them up? Because that's not only stressful for the customer / patient, it's really stressful for the caregiver as well. I mean, when you get that call, okay, mom was taken to a hospital, where is she, what's going on? If you can intervene ahead of time, that's really important. And I think that's also important in achieving that goal of keeping people in their homes longer, right? So if you have that situation where mom's taken via ambulance to an emergency room for an issue, those conversations may start to happen to say, hey, we need to maybe look for another place for mom to stay. But if you can intervene ahead of time and get mom, say, an antibiotic or something to that effect, everything just continues to move forward and they stay in the place where they really want to be. And there's plenty of studies out there that show that seniors really would prefer to be at the place that they call home. For a couple, that's what they're used to. The costs associated with, moving into, say, assisted living and things like that. If we can extend that longer, we think there's tremendous value for those customers.
Yeah, absolutely. And our data, definitely follows that. And also, older consumers actually don't want to move in with their children.
Right.
So that's not a solution that they're looking for. But I think that psychological impact, even with an ambulance coming, I was talking to some people recently in the safety and security arena around school safety and that response time and how those police responders might come into a school with a false alarm, right? They're traumatizing the children, not on purpose, right? They're doing their job to respond. But if they can get additional information that makes them understand whether that threat is real or not, or the severity of the threat, so that they could perhaps adjust the response to be appropriate to help, with whoever's in that environment. I think it is a really good point as well here with the family members and the senior. Getting carted off in an ambulance for something is scary if they're already concerned about maybe their health care and where they're at with their current conditions. I'm going to interrupt our questions with some questions from the audience to make sure I can get those in. So here is one for you, Andy. How important do you feel passive detection is rather than relying solely on the subject to initiate an emergency call? And then in parentheses, fall detection is perhaps the most important case.
Absolutely. I think it's super important. And the ability to have fall detection, currently we offer fall detection. It's a pendant-based, device where if it falls, it'll detect the fall and send a signal as if a button was pushed. So we would get a signal saying we've detected a fall. I think it's incredibly important that can become more passive, non-pendant based, with different devices that can detect what's going on and determine if a fall potentially has happened without having to wear a pendant. People don't like to wear a pendant, just in general. They're not the most beautiful devices, right? They're not as something that people always want to wear and show off. We get that, and those are some things that we're working on. But if I don't want to wear it to bed, the falls happen a lot of times when I'm getting out of bed to say go to the bathroom. Right. So if we can do that with the passive piece of it is super important, so that the senior in the home really doesn't necessarily feel all this stuff going on in the background. And I think the data and being able to understand what's going on with the data and not put that on the caregiver or on the senior to try and interpret what's going on, with all these different points of data, the AI in the background, if you will, is going to be a key to that. So I think the passive piece of it is super important. We want the senior to go about their day. We want the caregiver to go about their day as well. But if we can make things easier on them so they're not constantly going through a checklist of did you do X, Y, and Z, Some of the things that we've talked to some potential partners that are appliance manufacturers. Like if I can get, and some appliance manufacturers do this, but if I can put a camera in the fridge, and you're like, how does that work for a senior? How does that help? Well, if I'm a caregiver and I have to go to mom's house, inventory, I have to make a trip there, inventory the fridge, go back to the grocery store, bring all that stuff back. If I could look at the camera on the fridge or see an inventory of what's going on in the fridge, I don't have to take 2 trips, go back, come back. That relieves a different pressure for my day. I can just do it all in one stop, go in, bring all the stuff that we need, or potentially even have it delivered. Right.
That's what I was going to say there. I'm not somebody who would call to have my groceries delivered in my house at all. However, I can see the use case if I had somebody who needed groceries and needed help, because I have trouble, getting my own stuff done. And so that opportunity to help serve somebody that I love with a service that makes my life easier, and certainly a willingness to pay for that as well. So we're seeing that show up, delivery services, and I think different bundles that can come along with that are going to be interesting to watch as they unfold. I've got. Go ahead.
I think you have delivery services. There's potential for like concierge services where if you can't check in with the loved one, there's an ability for, say, an agent to call and check in with that loved one via video call, on a television, et cetera. As well as even house calls for, different doctor groups to go out and do a house call for, because that's a big piece of it too. Seniors don't get to the hospital until they're really sick a lot of times. So if I can make that as easy as possible, either through transportation or getting someone to the house to do whatever they need to do to check in on that senior, is really important as well.
Yeah, and ultimately, this is more than just like the healthcare aspect for an older person. There's so many different things that are factors that play into how well they're doing, and be able to communicate with people, be able to get around, be able to get good food, and have access to this through some different monitoring, I think is really an interesting play for the future. We've got some questions coming in, some things we were going to talk about in terms of the caregiver mindset versus the older senior who might be on their own making a purchase. So can you share some of the different marketing messages or differences that you see in how you might be approaching caretakers and caregivers? How does this selling work, to get somebody into services like these?
I think it's important to show, say, let's talk with the senior side first, how this can make their life better. What kind of conveniences can this provide in terms of just running the day-to-day of the house, and making sure that they're staying healthy and connected. A voice assistant may remind you to take a medication that you're supposed to take, or make sure you're drinking water and things like that. And those are relatively simple. And on the caregiver side, I think it's all about kind of what we talked about, reducing that stress, because frequently caregivers aren't just taking care of older loved ones. They may have younger loved ones that they're taking care of as well, and having to balance and juggle all of that is super important. So I think there's a group where seniors may buy this and say, hey, I can stay in my house for a longer period of time. Maybe one senior is a little bit more active than the other, and they're trying to just care for that person in their house. And really the goal is, can we keep you in here longer? And then the other piece is, can we make the caregiver as comfortable and make their life as stress-free as possible, so that they can take care of the things that they're doing, and then they're not at a point where they're going to ultimately throw up their arms and be like, we've got to do something and get more help, or move mom out, etc. I think there's kind of two different marketing messages there. And I think striking that chord and showing folks, I can provide you X amount or X percent of services that you might get in an assisted living facility for, say, 10 or 20% of the cost, I think can be a really compelling value proposition for those folks. Because I think what happens a lot of times is seniors, I'm going through this myself, my parents, my mom's got this vision of where she may move at some point, and I call it the cruise ship that doesn't move, right? The opulent place where everyone's, having good fun and whatnot. And I think when you get to some of those places, the sticker shock can be quite extreme. And they're like, whoa, I didn't realize it was going to be, this much. I'd rather stay at home. How can I provide a lot of those services, if you will, at a lower cost and keep you in that and extend that time in your home, which again, we talk about frequently. That's where they want to be.
Yeah, and there's also new models with caregiving where, you might have 4 seniors living together in a house and shared spaces, and then caregivers coming in and be able to, do that caretaking role in a way that, the individual isn't ultimately alone, but is still in a home environment, but not.
Really interesting.
Yeah, so there's lots of new models coming out. I think challenges in how to address the individual, right? Because everybody is an individual, as are their family members or whoever might be involved with their care. I can't have this conversation end without talking about Matter.
Yep.
This is a huge topic in the smart home and the connected home space, and so I'd love to hear any views you'd like to share on Matter. They launched, I think, yesterday, this week, and sharing that new standard. So tell us maybe how ADT is involved, what you think about standards in general, and what does Matter mean for the connected home industry?
I think it's for our vision of where we're going, which I've kind of explained, is I think it's essential that we have standards so that we have complete interoperability and give customers the opportunity to customize based on what their needs are and connect different devices that will provide different inputs or pieces of data based on what they need, because not everyone has the same ailment or has the same challenges. Some folks may want a more scaled down version of a system. Some folks may want more. And again, it's not just the health side of things. It's not necessarily, while it's important, some folks may need to take frequent readings of different biometrics, blood pressure or heart rate and things like that. That's all very important, but also tying in that home automation components where something as simple as when I wake up, I can turn on a night light and I'm not blinded, but I'm not going to trip over something on the way to the bathroom, or just all the different devices that are out there that are really exciting that, we're not going to necessarily be selling per se in a giant catalog of you get X, Y, and Z from ADT, but like things like a smart toilet seat, which I know is an interesting concept, but you can get a lot of data from that. Can I connect that because if I have a specific need? So I think the Matter and the ability for all this stuff to talk, interact, share data is essential to the success of what we're trying to do. Otherwise, like it's just having different standards is going to create different kinds of issues, and folks aren't going to be able to connect to it. If I can add different nodes to that system based on what those needs are, and then provide insights based on what data they're generating for us, and very simple insights that a caregiver can say, okay, something's going on, let me make a phone call, maybe we need to get a doctor involved. Not like someone trying to add up, like, okay, mom moved into the bathroom 8 times here and then she slept a little later this time, and then like trying to figure all that out. If we're just feeding data to someone, it's not going to work. It's got to be able to be insightful and say something is up, it's worth a check, you should check these different things.
Yeah, and that phenomenon is happening all over the connected home and IoT space. We've been talking about data and big data for at least a decade now, and finally realizing, you got to figure out what data is the important data to pay attention to. And certainly in the healthcare space with specific conditions, sometimes it's different data. You may need a blood pressure, you may need their oxygen levels. These are very specific metrics that combined can give some intelligence view that you might not have had otherwise. And I think that is ultimately the beauty of technology, be able to come up with something that otherwise you wouldn't have been able to. You noted the orchestration of devices coming together, and I do think this is one big orchestration. And when we bring in the connected health market, combining it in with the smart home space, which is a lot of different ecosystems, there's huge opportunity and also huge challenges, as we know, ones that you all are looking to solve. So as the final question, it's always amazing how quickly the time can go by. Can you share, where are we going to be in 5 years? I can certainly follow up with some of our forecast data, but, will this really become a reality? And where, maybe in the evolution, do you see where we are in this spot. Will there be big catalysts in the next 5 years? Certainly Matter could be one. What else do you think is going to happen 5 years out from now?
I think there's a couple things. So number one, I think Matter is huge. I think you're absolutely spot on there. I think as the technology becomes easier to use, integrate with one another, that data starts to drive insights, and we're keeping people safe. The outcomes data is super important as well, because I think that's going to drive insurance companies and payers to start to say, hey, this makes sense. I can actually keep someone safer, and I can anticipate things that may be happening down the road that would end up costing me a lot more money with an emergency room visit, if you will. I can keep people out of the hospital. I can keep people from being readmitted to the hospital. So I think as the data starts to come in, and we're able to synthesize that and make sense of it, make lives easier for, say, seniors and caregivers, which is super important for adoption. I think the ability to link that to outcomes is going to be a key catalyst to folks saying, hey, this is worth the investment here, and we can pay for this, and we'll get a return on it in terms of reducing admissions to hospitals, reducing bad outcomes or serious outcomes, et cetera. So that's a key to us. I mean, basically right now, the way we're set up is we lose customers two ways. They pass away, or they move into assisted living. And we want to try and extend that a little bit longer, as long as we can, and keep them with us and keep them in that place that they want to be. So that's super important for us.
Yeah, absolutely. Well, Andy, I want to thank you for your time. We really appreciate ADT's continued support of Parks Associates research and events, and we know your time is valuable. So thank you so much for joining us today.
Thanks for having me. This is great.
Okay, great. And if you'll stick with us, we're going to come back with a session on hospital to home. I just recently was able to attend the Medical Alert Monitoring Association annual event, which was really interesting, gave me some insight into what that group's thinking about. And I think today, this next session is going to touch on a lot of these issues with remote patient monitoring. So give us just a minute and we'll be right back. Thank you for joining us.
The consumer analytics team provides quantitative market intelligence that guides strategic business decisions. We explain market trends, predict how consumers will react to innovations, and recommend strategies for thriving in a changing business environment. We welcome any direct comments at jennifer.kent@parksassociates.com. Retailers, service providers, and device manufacturers are expanding the market of technology solutions that help seniors live safely and well in their homes. Our new research, Senior Living Technology for Safety and Independence, analyzes the existing and anticipated independent living needs among people ages 65 and older, as well as their family caregivers. It explores seniors' use of technology, attitudes towards and use of PERS and telehealth solutions, and tests interest and likelihood to buy selected solutions and services, including those enabled by smart home technologies and products. Key questions addressed include the following. What is the market size and characteristics for family caregiving solutions? What are the drivers and barriers of solution adoption? Which channels do consumers most prefer acquiring solutions from? What features and functionalities do family caregivers look for in solutions? How does the independent seniors market differ from the family caregiver market? How are seniors approaching the telehealth and connected health device markets? Our analysts are constantly studying this market and provide regular updates on the consumer healthcare market, including service features, key service differentiators, device adoption, pricing and business models, updates on existing players, and the impact on the caregiver market. To subscribe or request more information, please contact us at sales@parksassociates.com.
Hi, and welcome back. I'm Jennifer Kent, Vice President of Research with Parks Associates, and so pleased to be hosting this next session, focusing all on the transition of care from hospital to home, in particular, hospital at home and remote patient monitoring programs, really leveraging devices, monitoring services, and people in the home. So we're going to be talking about a couple of key issues with our panel of experts today to talk about the growing ways that technology is making possible a shift to care outside of the facility and into the home. We're going to talk about the leading use cases, the difference between hospital at home and remote patient monitoring programs, and the role of technology enabling these new services, and just as important, the role of people, support staff, family caregivers, home care clinicians and caregivers into the home, the reimbursement requirements and gaps in care that hospital at home programs or in virtual care programs may be addressing, and the biggest challenges to solve as more care shifts into the home, particularly under a hospital at home program and model. Now, alongside this movement of care into the home, we are seeing from our own research a dramatic uptick in households that do have some connected health devices in their home. So defined broadly, 54% of U.S. broadband or internet households own at least one wearable or connected weight scale, smart blood pressure cuff, or any number of connected medical devices or wellness devices that are now available through employee wellness programs, remote patient monitoring programs, or directly to the consumer. Now, when we talk about hospital at home or remote patient monitoring programs, we're typically talking about devices that have been provided to the patient, often in a kit. Traditionally and most frequently, it's to monitor a chronic condition like diabetes or COPD, or to diagnose a potential issue such as a cardiac condition or a sleep problem like sleep apnea, with a connected CPAP monitor, or other issue that might be best detected outside of the physician's office and in the course of that person's normal day. Now, recently, connected medical devices and sensors in the home are also being used to monitor a patient's recovery from illness, particularly COVID-19, of course, or to monitor a patient's status after they're released from the hospital, often for a certain number of days or months, or just to manage their condition. So taking all of these use cases together, about 40% of consumers in U.S. internet households report that they have participated at some time in some sort of, remote program, a program where clinician is remotely monitoring their health. We have an awesome group of powerhouse speakers to talk about this important topic, and I'm so pleased to introduce them. I'm going to ask them each to introduce themselves, tell you a little bit about themselves and about their organization. So I'm so pleased to start with Tim Balls, who's the CEO of Caligon Incorporated. So Tim, please tell us a little bit about yourself and your organization.
Yeah. So I'm Tim Balls. At Caligon, we make the world's first smart cushion, primarily for people with mobility issues right now, but we're working on expanding that. We focus on preventing pressure injuries, and we're a very technology focused company that's made up of a lot of ex-NASA and SpaceX engineers.
Fantastic. Thank you so much for joining today. Very interested in hearing your insights and more about your organization and your products here. Next, we have Ed Lear, who's the SVP of Business Development with V1 Health. Hi, Ed.
Hey, hello. Nice to join you guys today. V1 is a virtual care company where we have both the physician services and the virtual care platform that covers a patient throughout the whole continuum of care. Our physicians are really own and direct the company, so their focus is on the quality of care and making sure the patient is covered, whether they're in the hospital, outside the hospital, or wherever. So we deal with interventions, consultations, and monitoring and managing that patient remotely wherever they are.
Wonderful. Thank you so much for joining us today. Next, we have Dr. Taki Michaelidis, who's the Medical Director of Hospital at Home with UMass Memorial Health. Hi, Taki, how are you?
Hi, Jennifer. It's a pleasure. My name is Taki Michaelidis. I'm an internal medicine physician by training and a hospitalist and medical director of the Hospital at Home program at UMass Memorial Health. I'm joined by my colleague Deirdre, who will join and introduce herself in a second. But UMass Memorial Health is the primary safety net health system in central Massachusetts. We care for a very socioeconomically disadvantaged population and provide the vast majority of primary and tertiary care in our region in Massachusetts. So it's a pleasure.
We are definitely excited to have the power duo dream team here from UMass Memorial Health. So let's invite Deirdre to introduce herself as well. Hi, Deirdre, how are you?
Hi, Jen. Thanks so much for having us. My name's Deirdre Raleigh. I'm the nurse manager for the Hospital at Home program here at UMass. And like Taki said, we are serving our community in their homes, giving acute care, hospital level of care in their homes. And we are identifying all sorts of inequalities amongst our community and getting great health care and getting them tucked in at discharge with services that are really helping them in the long run. And it's a real staff pleaser having this as a job in comparison to working in the brick and mortar. We find that nurses are really happy in this program.
Yeah, I'm so interested to hear about that. You know, a lot of what we hear about on how the technology is working in various models of connecting the facility to the home is really about the staffing and the workflow. Really important topic to get into. So thank you so much for joining us.
Yeah.
Chris Stark, who's the Chief Clinical Officer with Landmark Health. Hi, Chris.
Hello.
Tell us a little bit more about yourself and about Landmark.
Sure. So I'm Chris Stark. I'm the Chief Clinical Officer for Landmark Health for the Central States. I've been with Landmark for about 6 years now, but I'm an ER doctor by training in academic medical centers for about 20 years prior to that. So I joined Landmark 6 years ago to take care of patients in their home to keep them out of the emergency department. So we extend geriatric mobile care into the patient's home in urban, semi-rural, rural communities throughout the United States. We're in about 39 states right now and 500,000 patients this year, climbing to over 1 million patients next year. So we do routine care and urgent care in the home, driving outcomes like decreased admissions, decreased SNF admissions, decreased costs, decreased mortality rates. So we essentially do the modern house call, both routine visits and urgent visits.
I'm very excited to see the modern house call making a comeback. I think it's really interesting and innovative and a new way to experience care. So thank you, Chris. And finally, we have Feridun Teslimi, who's the CEO of Sensors Call. Hi, Feridun.
Hi, good morning or good afternoon. My name is Feridun Teslimi. I'm the founder of Sensors Call. The reason I started Sensors Call was a few years ago, I saw my wife looking after her mom, who lives right down the road from us. And she was always concerned about her well-being. And these purse devices and things you put around your neck doesn't really tell you whether she's okay. So this is how this device came about. There's no camera and it doesn't listen to you. You put one in the bathroom, one in the bedroom, one in the kitchen, living room area. And basically the machine learning tells you exactly how everything is. And if she's okay, she got back from shopping or she took a shower, everything was fine. And recently, unfortunately, we've had, she's been to the hospital about 7 times. And so what we've done is we've added the biometric information to it, the heart rate. She needs to look at her oxygen level constantly. So we actually monitor that using a very inexpensive oximeter through this device, and it sends it to the dashboard. So that's what Sensors Call is.
Okay, fantastic. So a lot of different perspectives here on the panel today, which is really fantastic. What I'd love to lead off with is to get a perspective. I'm going to go to Taki, to you here first, and then over to Ed, to tell us a little bit about how you see hospital at home programs fitting into the larger, universe of ways of seeing and treating patients. and how you see these programs becoming a more kind of long-term sustainable part of the healthcare ecosystem. So Taki, I'd love to start with you there.
No, Jennifer, thank you for that question. It's a fun question. And probably all of our panelists might agree that we are oriented as a team around keeping our complex patients who are older, often more chronically ill, where we know those folks when they develop an acute medical complaint, any acute issue that brings them to the hospital, we know that oftentimes institutional settings don't serve those patients as well. And so I think the folks on this panel, all of us are oriented around keeping those folks at home, safe, well, surrounded by their loved ones and their families. And so in many ways, the panel that you're seeing in front of you here is a very value-based panel in many ways. We're not doing surgical procedures together. We're not doing things that ideally we would like to prevent as a team. And so I hope that home hospital, and again, home hospital for us is the case with many CMS waiver home hospital programs across the country. Home hospital is really about replacing the hospitalization entirely and bringing that high acuity inpatient level care to the home. So we'll care for vulnerable folks who present to the emergency department with pneumonia requiring oxygen, who are quite sick, would otherwise be admitted to the floor or upstairs. And we say to them, we can set up a temporary hospital in your home instead. And we bring all that care, the nursing, the physicians, the paramedics, the labs, the EKG, the ultrasound, the x-ray, all of those services to the home. And we do whatever we can to keep folks delighted and happy and surrounded by their loved ones. Our outcomes are fantastic. And it's an absolute privilege to be invited into their homes in these moments of vulnerability. And frankly, we're building trust in these moments. So I think I'm looking forward to this conversation with this team.
Yeah, I'd love to hear even more specifically around maybe some of you gave a great use case right there, right? Someone coming in with pneumonia, they need oxygen. And then how, right? Like that next step happens. Like how do you get them set up? What are those first moments? Because I do feel like the onboarding, the support, giving people the confidence that this is something that they can do at home and that they're well taken care of. What does that look like?
It's a really fun question, and my colleague Deirdre will talk a lot more about this as well. The short answer is that we provide hospital care in the home and we bring everything to them. So we meet the patient's transported home by ambulance, they're met by our nurse or paramedic or both sometimes outside the home. We install our technology remote monitoring platform in the home. They do a tuck-in visit with our physician on video visit. And then we bring the intravenous medications, the fluids, the diuretics, all the normal hospital care to the home. And our nurses are in the home 2, 3, 4, 5, 6 times a day. Managing acutely ill patients. So probably one thematic point I might just share is that the more acutely ill folks become, the more complex, often the more disadvantaged they become, the more grossly inadequate a tech alone solution is. It's about a technology and a humanity solution knit together in a way that's seamless for the patient. So that's how we do it.
Yeah, awesome. Well, and let me turn to you there too, and getting your thought on, again, how these hospital at home programs really fit into you. I actually had a nice slide when you were introducing yourself and V1 Health about sort of this, the different areas that you provide support with remote patient monitoring and hospital at home called out separately. For those who aren't living and breathing it every day, a lot of times remote patient monitoring is more of a chronic monitoring, ongoing monitoring, perhaps, where hospital at home is more acute. From your point of view in the ecosystem, how do you see hospital at home fitting into the larger, healthcare future, really?
And you're asking me, correct?
Yes, Ed, thanks.
Thanks. It's a definition issue to some extent. I like Take's comment. RPM, all these acronyms, remote, we call it remote. I mean, we use the M as management, not monitoring, because you're managing the patient and whether, what do you need to do to manage that patient, whether it's a low acuity, all the way up to, virtual ICU, RPM ICU, which is a product that we're coming out with. So it's basically the technology is one thing, but it's really coordinating all the activities of what's common in the hospital today and put those workflows so they can have that same level of service in the home. When you say details, today people usually start out with lower acuities because they want to start out with a little lower risk and feel comfortable, get all their processes and procedures in place. And then move up the acuity level as they feel comfortable. And it's also having to do with really their particular situation because you want to have some volume of patients. So you just don't want to start out with, oh, these guys over here have done it this way, so we want to do it that way, even though you might only have one patient a month in that particular situation, and you really are not satisfying your business goals. So you have to match that too. Hopefully I didn't take too much time there.
No, that's perfect, and that's really good insight too about how to make those business decisions of which conditions or situations might be appropriate for this type of program. Now, Taki brought up a really nice point about how there's it's not just the technology, right? There's a technology side, there's a people side, and I kind of want to get into both. So Faridun and Tim, I'd love to start talking to you all about the technology side, right? And the role of technology that it plays in allowing more care to be shifted into the home. If you can tell us a little bit more about Faridun, to start with you about the role of the sensors and the data that you're collecting, and how that can be, acted on, actionably by either family caregivers or clinicians.
I heard somebody in the previous panel talk about ultra wideband technology. I remember 20 years ago, I played with that, and the antenna was this big, and the circuitry was this big. Now you can do it with a little chip. This is small. I mean, it's unbelievable what is happening. In this little device here, we have 10 sensors, air quality, and all kinds of stuff, information that we are gathering. It's unbelievable. And the sensor technology is moving incredibly fast. We have now radar technology. You can buy a radar chip for about $2. The question is, how do you gather that information? How do you analyze it? But then the other thing that is happening is this machine learning and AI on the edge. Because one of the things we found that a lot of people don't really like to put this stuff in the cloud. They don't trust it. They think somebody may steal it. But then now you can actually do a lot of stuff right on the chip inside this little device here, which is plugged into the wall. And the processor we're using is only $3. So with a $3 processor, we can do unbelievable amount of processing and figure out what the person is doing. So the role of the technology is incredible, and as the time goes on, it's getting better and better.
Faridun, let me follow up with a point about doing AI on the edge and keeping more of that data collection and processing there. Definitely our research shows that people are concerned about privacy and security, and healthcare is a particularly vulnerable place, right? Very personal data people are nervous about connected solutions, perhaps. Do they understand, right, the keeping the data local versus having it on the cloud? Is that something that you're actively talking about with users?
Well, that's a part of education that you have to convey to people, that your data is actually resides here, not in the cloud as much. We may do some inference in the cloud and then send the inference back in here, and everything else is anonymized. But that's the point that you have to get across, that there's a lot of security in having the data in your own device as opposed to somewhere else.
Yep. Now, Tim, tell us a little bit more about what information that your solution can pick up, right, and how that's helping people have better care at home.
Yeah, so we really first focus on the needs and use cases. So the thing that I think is really important is how do you create something that fits within people's workflow and provides not too much information and only like actionable information. What we've found for us is, initially we provided some of our some clinicians large amounts of data, but it almost can be overwhelming. So what we really started focusing on is activity levels, and then looking at therapy adherence. So, for example, people that are high risk for pressure injuries, performing offloads, which is where you basically do like a weight shift or actually lift yourself up to try to keep from having blood flow cut off. That is something that's very, very difficult for most individuals to have proper adherence for. I really don't think it is compliance, because it is just quite difficult to do it, because you need to do it every 15 minutes when you're seated. And so what we do is we track that adherence, and we try to from the user standpoint, provide them with information for them to understand what they're doing well and what they can improve. And from the clinician standpoint, give them information so that they can understand if, when that patient is away from them, if they're in a high risk situation.
And so the information that you're detecting, right, are those alerts going back to the user and to the clinician, so they're both seeing if there's shift that needs to be made or family caregivers?
Yeah. So right now, what we're doing is we're actually experimenting with how we want to roll this out on a larger scale. We've got this set up with beta testing currently. We're working with clinicians to really find where the value props are there. So we're able to provide clinicians a weekly report of activity levels. And then for users, we can provide them those same reports. So we're still figuring out whether we want how much we want the information sent on a day-to-day basis, because we don't want it to be so overwhelming that people just stop using the device or stop using the data. So right now we're doing primarily weekly reports. And so, yeah.
Yeah, interesting. Now, Chris, I know that we talked a little bit earlier this week, and you mentioned that we're talking a lot about data and then the algorithms and what data is too much. There's not just the technology in the home, there's the technology that's feeding the right information back into the clinical workflows. Can you talk a little bit about how you are using the data that you might be seeing, to Tim's point, right, within your own organization?
Yeah, so the way we look at it, so the modern house call as we see it not only requires patient-facing technology, we use most of our technology on the back end. So the patient doesn't see most of the sophistication that goes behind our processes. So our electronic medical records and health information exchanges to kind of get that accurate and complete documentation together. Panel management tools, robust operational management dashboards and reporting. So we'll do reporting on daily basis, weekly, monthly, quarterly, and yearly to follow trends, figure out in advance to be proactive. So we do an awful lot of looking at the past to predict the future. And we have a dedicated data science and predictive analytics team that works with us that helps us analyze all this data so that we can stratify people in advance into risk groups for palliative care, for hospice, for risks of admission and decline, and use frailty scores and all kinds of different tools and techniques and data images to try and keep people safe and at home as long as we can.
Yep. Now, we actually have a question from the audience that works really well into what we're talking about right here. So I'm going to go ahead and take it early. And this might be a good one for you, Chris or Tim, but anybody's welcome to jump in. The question is there any need for healthcare providers to view the health of the patient's network as well as the patient's health? That is, the status of the technology that's deployed into the home, the sensors, the tablets, their data flow back to providers, that it's all active and live. Now, in hospital at home programs, a lot of times they are cellular kits, right? So you're not relying on the home network, but that might not be the case in every case. Now, I saw Ed come off mute, so I didn't know if you were trying to jump in there. But you're welcome to. But that question's open to anybody.
You're asking if the clinical side is interested. We lost you there a second. You're asking if the clinical side is interested in the technical infrastructure of what's going on with the performance or quality of the technical infrastructure. Is that what you're asking?
Right. So, I mean, the question from the audience is there any need for healthcare providers to view the health of the network? I'm sure the clinicians have no interest in viewing the health of the network, but is there a role, an opportunity for a player in there to make sure that they're watching if the devices and sensors are online or offline, right? And making sure that they're up and acting appropriately.
Oh, yeah. That's part of the whole operational side is just like anything, to make sure your sensors are just in the inpatient of the hospital. They do the same thing to make sure you're online all the time. So you have to do the same thing when you're remote. So it's very critical.
Okay. And Faridun did raise his hand as well. And I saw Deirdre came off. So Faridun, and then we'll go over to Deirdre.
Well, in our case, our backend actually looks at the health of each sensor. If something goes wrong, it sends an alert to the caregiver saying that this sensor is off. So obviously, if you're looking at something very important, you want to know if the sensor is actually working and if the data is updated.
Yep. Okay. And Deirdre, did you want to chime in there?
I was just going to say the same thing. We do monitor the monitors in a sense, just to make sure that batteries are always charged for our patients, and if they're online or offline. So yeah, clinicians are concerned if the monitors
the
need to be monitored.
clinicians check out the high tech things as well as the low tech things. You know, when you go into the home, you're there to see that connectivity is working, that the devices are working, their scale is working when they have congestive heart failure, and you're monitoring their weights every day, but also that their pill bottles are correct, that their cupboards are full of good food, and all the different low tech things as well.
And just to add,
okay, please.
Oh no, I was just going to add to Chris's point too. I've also never seen a sensor that's nearly as good as a son or daughter who is worried about how mom or dad or grandma or grandpa is doing. So if we're not talking about the health of that sensor network, we're also missing a key point.
Yeah, I love that. And that really bridges right into the next question, which really is a focus on the people side, right? And so Deirdre, I'd love to come to you and then back over to Chris. So tell us really about the role that you're seeing for the staff and family caregivers, right, in making care at home work.
You know, I think that people need to think about what the patient is like in the hospital. So their independence is taken away. They have no control on their care plan. Getting these patients back to their house, there is time for education, not only for the patient, but the family. You're giving back the power to the patient themselves on their disease process. In the brick and mortar setting, a nurse may be interrupted 3 times in a teaching session. When you are in their own environment where they're comfortable, they have that learning experience, and the nurses can do what they want to do with these patients, which is give them the teach, and then make sure that everyone's involved in it. And it's good for preventative care, for readmissions. It's equipment, checking out equipment. You wonder why some COPD patients come back and forth to the hospital. Well, their nebulizer hasn't worked in 6 months and no one knew it until someone got into the house. It's multifaceted, and what we're finding is patients feel that they have concierge medicine. They're the only person that anyone cares about for that 1 hour a day. We're in the hustle and bustle of a brick and mortar setting. That's not how it is. It's people in and out all day long. And so just that comfort level for them and comfort level for staff being welcomed into their home has really shown to be a great outcome for our patients.
Yeah, and there was a comment on the prior panel about how healthcare is really pushing into caring about these social determinants of health, and the ability to have eyeballs into the home setting. You know, for the first time, maybe you are really seeing a more holistic view of that patient's circumstances and other causes that maybe could be addressed for better outcomes. So, Chris, you know, to you as well, I'm interested in, obviously, Landmark has staff coming into the home. Tell us about, you know, operationally how that's working, and also kind of especially how the staff are interacting with the technologies that are making this possible too. Are they providing a install, setup, support mode and training as well?
Yeah, I'll go by telling 2 stories. So we'll start with pre-pandemic. So we were 100% in the home, sending our entire interdisciplinary team in. So we would send in providers to go do the medical care, social workers to go in and sit and deal with all the SDOH problems that were coming up, behavioral health providers who would go in and take away some of that stigma of going into the behavioral health office, and they would come into the home and prescribe medications and take care of all their behavioral health needs. Nurses doing triage and telephone lines and all the stuff that went along with medicine before the pandemic. And then one day happened and we went 100% virtual the next day, and we couldn't go into the home. So we had already had a telemedicine system set up, so we were all set for it. We converted over. We had to educate providers on how to do telemedicine visits because it's a lot different than sitting in the home, what you can and what you can't see and do and take care of. And then About 3 months into it, we then acquired enough PPE and had enough data to understand that those people in the home was super valuable. The technology and all the telehealth and all the devices were great, but without those providers in the home, we were missing the mark. That they really needed that high touch system. So we've now kind of gone into an 80-20 scenario where we're in the home 80% of the time, and we've retained about 20% of the telephonic system with all of our different divisions. So that really kind of taught us where we were really doing our most impact.
Yeah, thanks for sharing those stories. Now, one thing we hear a lot about, right, that I'm interested in hearing from you, and also Deirdre or Taki, if you want to chime in, is around, the great staffing shortages that everybody is dealing with, right? How are you dealing with that in your organizations? Does the technology help? Is moving into the home a different type of staff? Is there a different type of worker who is attracted to working the hospital at home programs than maybe in the facility? What can you share there on the staffing? I'll start with Chris and then go to Deirdre.
So staffing shortages, as we heard from the previous conversations, are hitting everybody. But yeah, so we've changed and modified as we've gone along. So we still have our providers and our behavioral health providers, but we've started branching into licensed social workers as well to help support the behavioral health providers. We also have what we call urgentivist extenders, who are paramedics. They're LPNs who go into the home as a first line for some of our urgent visits, and then do a video assisted visit with either a doctor or a nurse practitioner back at our central call center. So utilizing those different staff members along with the video technology helps us see more people and help take care of more people. In addition, that back-end technology helps us keep people more efficient. We decrease our windshield time of people driving between different visits. We, adjust our acuity so that the patients are visited at different cadences, both face-to-face as well as virtually.
Deirdre, how about from your perspective on the staffing and how these programs are working out with broad staffing issues that we know are hitting the industry?
Yeah, they are hitting the industry, and what you're finding is that a lot of nurses and paramedics that have come to work in our program had hit the burnout, especially after the couple of years being in the hospital and being surrounded by horrific events for 2 straight years, and getting back into the home with a new care model has really invigorated them again. They've loved their careers again. They feel useful again. All things that were contributing to why so many caregivers are leaving medicine, because they don't feel a purpose any longer. And I think these care models are definitely opening the eyes to a lot of different clinicians that there is an alternative to take care of our patients in a great way and have good outcomes. And that's really an important thing, that when you are doing staff recruiting, that this is a different model where it's an ownership of your patients in a sense, where you'll get your satisfaction, your job satisfaction back. And so we've had a bit of luck of getting staff to actually join our team.
That's really an incredible point. I mean, you're talking not only about humanizing the patient when they're at home, but also the healthcare worker as well, really. Now, we actually do have another question kind of right on this topic, so happy to incorporate it here. And Deirdre, actually, this is probably right back to you. How hard is it for nurses and doctors to incorporate change? How frequently do you feel like, and Taki and Chris, you might chime in on this too, but how frequently are new solutions introduced, and do you feel like they can keep up with the pace of innovation, right? There's a lot of change when it comes to the technical side with telehealth, virtual systems over the past couple years. Are people feeling burnout on the pace of technology change in the healthcare system?
Taki, did you want to start with that? I'm just
the healthcare delivery system is the foundation of everything that we are doing, whether it's new technologies, new payment models. The delivery system still remains the concrete at the base of the house of care that we're delivering. Obviously, the goal is to always keep folks not requiring it because we're being so proactive and essentially preventative in that sort of model of care. So I do think that that does create some vulnerabilities if we are training nurses and paramedics and physicians and providers based on 30-year-old approaches and 30-year-old systems of data. And so we do need to move forward. There are, frankly, in training, did I ever do a house call? Never. Did we talk about social determinants enough? Never. Did I ever do telehealth when I left training? No. And so these are some basic foundational things that we're just missing in our training programs. We're in the process of incorporating a lot of that into our new providers, in particular on the provider side in our home hospital program. But it's still early days, I think. And so we have, I think, a long ways to go in terms of technology and human centricity and thinking about patients more broadly. We have a very medical model of care in this country, and we need to obviously pivot that model to a much more holistic model.
Yep. Now, actually talking about that model that you mentioned at the end, we are interested in understanding exactly how you're designing these programs, whether it's directly for reimbursement or with several of you mentioned, you're a value-based care model, and so really, if this is bringing down costs and improving outcomes, then it's worth the investment. Maybe Ed, I'll go to you first. How does V1 Health, you're serving different types of clients, right? How is the model working for hospital at home programs?
The model is not the model. Let's just put it that way. There's a lot of models. It all depends on your population, depends on your resources that you have. So there's not just one model in hospital at home or managing a patient. There, you have the basic stuff that you have to have. You have to have the pharmacy, the DME. You have to have all the components of home health. All those things you have to have. But as far as a particular model, now as far as on the financial reimbursement side, that's also depends on the particular hospital, where they are on the at-risk model, the value-based model. Most of them aren't as far along as they probably want to be right now. But, clearly hospital home fits so well in the value-based side because payers are very interested in moving towards this because the obvious reason of reduced costs. So I don't know if I answered your question or not, but there are a lot of, I guess, models depending on what you want to do. But in general, I think Take and Deidre probably have a better understanding of kind of maybe their generic model, depending on what population they're going to try to tackle, what acuity level they're going to try to tackle. Are they going to try to tackle readmissions? Are they going to try to tackle admissions period and try to get the patient not to be admitted directly into the inpatient, but go directly to home? It really depends on what their business role is or their business direction to know what that model is. Sorry to be long-winded.
No, well, it speaks to the necessity to kind of be open and be flexible to see what matters. Now, I'd love to actually ask Tim and Faridun as well, from the product side, right? Do you fit into the reimbursement model? Do you do any direct to consumer pay? And how do you see these models kind of shifting in the future? So maybe Tim, I'll start with you and then go over to Faridun.
Yeah, so we're kind of hybrid right now. We do have some direct pay users. We also have the product itself is in the process of getting code verification for a non-remote patient monitoring code, but we are looking at how we can begin actually getting the reimbursement on the remote patient monitoring later on. So we came at it with codes that are more established that we could be very confident we can obtain reimbursement from, and then we're bringing in the remote patient monitoring later. So we're proving the value prop using other codes, and then we'll be able to roll that in as an additional service with the product.
Is there any concern? Do you have any concern about, certain codes, whether it's hospital care, remote patient monitoring, some codes, right, and initiatives are still under emergency waiver, I believe, right, about the sustainability going forward of these revenue streams, right? How do you guys think about that?
Well, that's the primary reason that we focused on using other codes, and bringing us into the market with the CRT, so complex rehab technology codes, instead of the emergency use codes, because we could be confident that there wouldn't be, a company ending situation that would happen if those reimbursements were removed.
Yep. Faridun, to you, right, for your solution, are you 100% consumer pays today? Or are you working into some of the other models, working, into the healthcare and clinical side?
U.S. is way behind most other countries. In Europe and some countries, they give you a chunk of money. You can use that for technology like ours. U.S. recently for biometric monitoring, they came up with a code that if your blood pressure and so on, and you have to get a prescription from the doctor, so they pay up to, I think, about $180. But for general activity monitoring and things like that, well-being monitoring, right now there is no reimbursement.
Okay, perfect. Well, so we have about 12 minutes left. There are a couple of topics I really wanted to get at. One is really about the ability for hospital at home programs to close gaps in care and to address access issues. And also we hear a lot on the technology side, right, about whether or not telehealth services and devices are actually leading to a new digital divide in care, and different types of access issues. And so, Deirdre, I'm going to come to you and then back to Tim on this. So how do you feel that your programs, do you feel like you're able to reach all the patient populations that you need to reach? Is it helping you to close the gaps in care? What perspective can you provide there?
Is we are taking care of patients that are consistent with what our city and our county represent. So we are representing every socioeconomic patient that lives around our medical center, and giving great care no matter what what is in the background for them.
And Taki, I saw you shaking your head.
Yeah.
Yes, there too.
The only piece I would add, and I agree with everything Deirdre said too, is that you have to design for equity in your programs. This is not like oh gosh, like, are we equitable or not equitable? Are you designing? Are you understanding the challenges and designing against those? So we bring food, we bring internet, we go into single room occupancy dorms, we're taking care of folks living in the attics of wake shops. There are some really, really, I think, challenging social situations that we find, and then we map resources to them, while bringing all the things that are disadvantaging that population to not otherwise be able to accept entry into our program. So a design philosophy, a measurement philosophy, and a monitoring philosophy, I think, is just critical for equity. And really, I think that's the only thing I'd add.
Okay, I think someone else is just jumping in there. That I cut off? No. Okay, go ahead, Tim. Sorry, Tim, I saw that you came off mute. But when Tim, if you're thinking about your own, solutions, right? Right now, I know again you're working on these reimbursement codes, and also have kind of a direct pays model. Do you feel like you're serving a population certainly that has very specific accessibility and mobility needs too, right? How do you feel you're able to your technology maybe is addressing gaps in care? Or that you're reaching all the populations you're trying to reach?
Yeah, no, it's so the specific sector we're working with, it's the technology integration in care is far behind even the other areas of healthcare. But what specifically talking to the hospital at home, I think there's some really good opportunities there. I can talk about a specific customer of ours. We weren't providing any of the hospital at home stuff with them, but they had an issue with that. And they were telling us a story about how they had about half of their care in the hospital, and they were able to do the second half, about 2 months of it actually out of the hospital in the home. And the hospital was significantly less accessible for them because they had a spinal cord injury. And so they were in a typical ICU room, which was not set up to provide them care. And once they were able to go home, they had, everything from their wheelchair that they couldn't transport that had, a tilt and space function. So instead of just having to lay in the bed, they now have an accessible seating surface because they actually weren't able to sit on any of the surfaces that were provided in the hospital. So in that specific case, the hospital at home, because they had a good home support network, actually gave them significantly improved care. And so I think there's a lot of both opportunities and risks as we move towards a hospital at home setup. I think as long as, like what Taki said, as long as we're really careful to assess the people's at home situation and take action if needed, if they don't have, if they don't have equitable or just really proper support, then I think there's huge opportunities for improvement as long as we keep that careful eye on it.
Yep. And yeah, please, Feridan, if you want to add there. I mean, you're serving seniors in particular. I think you're actually still on mute here. Okay, you're serving seniors in particular, who, when we're talking about technology-based solutions, oftentimes technology is not designed for seniors first. It's designed for early adopters who tend to be younger, wealthier, right? So can you talk a little bit about this as well?
Well, one of the issue is on the hospital at home is knowing whether the person is recovering or not. How do you know that? You call the patient every minute and ask them, are you okay? So that's where I think there's a lot of opportunity for technology. In our case, for example, we look at the activity. We have a baseline of activities, and we see all these. After you come back to your home, your activity is going to go down, but then gradually has to go back up. Your kitchen usage has to increase, and things like that. If that's not happening, that means there's something wrong. So that's where I think that technology can actually provide information that is useful for the caregivers and so on.
Yep,
Yeah.
absolutely. Go ahead, Tim.
I think you made a good point too on the baseline. Having an established baseline, I think, is important. I think that's really, especially with your technology, really important to be able to track. Are we getting back up to where we were before the issue, before a hospitalization? And that's for us to being able to see the activity levels when someone is sitting. We can actually see how much someone is moving, and we're beginning to look at how can we use that to provide better insight and care. And what we've very quickly realized is we have to have that baseline established beforehand. Otherwise, it becomes really, really difficult to evaluate the effectiveness of the care.
So, I love that you brought up that specific point, right? Like, this is one of those areas that there's so much progress being made in, right? And there's so much development and learning to be had and done. So I'd love to talk just a little bit with our time here on the challenges that still, are right in front of the hospital at home initiatives. One we talked about was, these reimbursement codes that are still on an emergency basis. So that's one thing to talk about. But Chris, I'm going to come to you first here. When you're thinking about, Landmark Health and your organization, what do you see as the biggest challenges in front of providing hospital level care at home in these type of, acute situations?
I think one of the most challenging things ahead of us is the volume of work that there is to do. So 77% of patients, of course, want to age at home. They want to stay at home. And it's been that way for a decade. Studies consistently show that people don't want to leave their houses. But only about 12% of the 4 million people who could use home-based medical care are actually receiving home-based medical care. Now, Landmark, we're going to be up to 1 million patients by the end of 2023. Last year, we saw 300,000 in-person visits, 75,000 urgent visits, and 100,000 virtual visits. And we're only hitting the tip of the iceberg of what's out there to do. So organizing us as a group, getting us all together, banding the technology around us to make this job easier is one of the biggest challenges that I see ahead of us.
Yep. Now, Taki, I see you're shaking your head yes. So I'd love to get your perspective too. When you're thinking about your hospital at home programs there at UMass Memorial Health, right? What are the challenges that are right in front of you?
I think First, I want to answer that question, but first, Chris, just want to 100% agree with you. Come to Central Massachusetts. We'd be delighted to work together for a complex population. I think to some degree what Chris is alluding to, that short of the landmarks of the world, there is a gap in service for complex patients in the home. Folks who are either hospital dependent or borderline hospital dependent who need these levels of services in the home, and the ambulatory care infrastructure is just grossly inadequate. And so you're talking about building something that's in between the hospital system and the primary care system. From the hospital home perspective, to answer your question though about reimbursement, prior to the pandemic and prior to the CMS waiver of November 2020 that facilitated reimbursement for hospital care at home, fee-for-service Medicare and Medicaid didn't reimburse for hospital at home. And so it's basically folks with commercial insurance or Medicare Advantage. So huge inequity in access to this safe and effective and patient-centered care model. The waiver comes along in November 2020, and suddenly there's reimbursement, and suddenly we can care for patients with Medicaid who are dual eligible with Medicare Advantage, with fee-for-service Medicare, essentially all payer and bring this level of care. So we are in the process of a really extensive advocacy efforts now to ensure that when the PHE goes away, which at some point, of course, it will, that Congress understands, that CMS understands what this will mean in terms of a loss. Because in our program, we're seeing 20 to 30% reductions in mortality in 30-day readmissions, the highest patient satisfaction scores in our health system. And so there's very few interventions in healthcare that are win, 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 and this is one of them. And so, but that said, Congress has a lot on their plate, and the world is a really busy place. And so most of what we're hearing from folks is lots of positivity, and just a matter of, can we get everything together to pass the legislation to extend the waiver after the PHE?
I love that you just give Congress the benefit of the doubt there. That's that's rare. I don't know. Very nice of you. But I do think what's interesting is that, like the stats that you just shared, 30% reduction in mortality. The past few years have given us all the opportunity to collect the data to prove out the outcomes. So that I think that is a nice place for hopefulness, right? Because there can be data that can be shared around the effectiveness of these programs for hopefully stabilizing that reimbursement. Faridun, I know that you were raising your hand there. Happy to get a thought from you on challenges. And then maybe Ed, if I would love to end with you as last word on the challenges that you think are right ahead of us in hospital to home care. And then I think we'll be out of time. But Faridun, go ahead.
Yeah, I just want to share with you a personal experience. The last time they brought my mother-in-law home, we came home with a ventilator and a few other things. And some of these equipments are complex, and there are some stuff we couldn't understand, and so that's where I think the technology has to come in. And especially if these devices become connected, something in the middle that actually reads this data and interprets it and actually gives you something in English that this is what you should do. My mother-in-law has COPD, and she shouldn't have too much oxygen. I had no idea. I didn't know that, So those are some of the things that I think technology can help.
Absolutely. Translating things to the actual patient, the user, right, of what these things mean and really empowering them. A challenge, but a big opportunity. Ed, last thoughts to you.
Well, I totally agree with Tiki as far as, I think everybody knows the value base that at risk is the future. I mean, there's no doubt. It's the stepping stone to get there. Congress hopefully will. And actually, everybody on this call, if you want to contact me, I'm part of the lobbyist group to deal with the Congress and the Emergency Act. So I would love to have statistics like you're pointing out, so we can get that in front of them. But so I think at risk is going to when the payers they understand the positive side of this thing. We've had discussions with some pretty major payers. They would love to set up programs like this. So I think that's going to happen. I think it's just a matter of when. I think as more and more hospitals and healthcare delivery systems move to this, consumerism is going to be coming into the play of this, and the whole sensor world is taken off to unbelievable areas where you have nanotechnology and fabrics, wearable devices that we interface with all these things. And it's just the holistic view that we have to bring all that data together and view it. So all this stuff is positive. It's just frustrating when you're when you're starting out here to go through all this learning curve. But I'm very positive that Congress is going to see the light, and all the payers are also understanding the positive aspects of this. There is really no negative aspect of this at all in everybody's view. It's just getting over that hump. So I'm going to leave it very optimistic here.
I love to leave it on that note. Taki, Deirdre just gave you some homework. If you can send him all your stats, he's gonna argue for us all. So that's fantastic. Faridun, Ed, Dr. Stark, Deirdre, Dr. Michaelides, thank you so much for joining us today. We really appreciate your time and your insights that you've shared with our audience. Thank you all so much.
Thanks so much,
thank you.
You.
So, fantastic. So with that, we're very pleased to wrap this Connected Health Summit session. Wanted to also let you all know that this is our last Connected Health Summit virtual session of 2022, but we are rolling right into 2023. We will be back in person with our Connected Health Summit in San Diego, which always happens that week right leading up into Labor Day. So please plan to attend and join us in San Diego in August, but we'll also have virtual sessions in January, April, and in November. Thank you very much to our sponsors for making the Connected Health Summit possible. ADT Medical Alert, Alarm.com, Johnson Controls, Rapid Response Monitoring, as well as Becklar and Independa. We appreciate your support. Parks Associates has published several different studies this year. We have been serving 10,000 internet households every quarter for about a decade. And every year we look at virtual care solutions, senior care solutions. What are consumers' familiarity with these types of services? What are their interests, their preferences? What are their questions about it? What are they looking for? So please, if you're interested, reach out to us about the telehealth and remote patient monitoring user experience study or the senior living technology for safety and independence study. And also, of course, we do offer custom marketing services like white papers, webinars, and podcasts. So if you're interested in sponsoring research, sponsoring our events, please reach out to any of our sales associates. Thank you very much. And we appreciate all of your attendance. You can go back and check out any of our recordings from throughout 2022 on the Swap Card platform through the end of the year. Then we'll be moving into 2023. Thank you.